Bismillah ar-Rahman ar-Rahim. Assalamu alaikum to you all. Good evening. Hello everyone everywhere. A very warm welcome to today's CAGS webinar session. My name is Dr. Aman Al-Taneji. I'm a consultant pediatrician and metabolic physician working in Abu Dhabi, United Arab Emirates. And it's my honor to be your host for today's webinar. And on behalf of the CAGS team, I'd like to thank you all for joining us in this scientific platform, which basically aims to expand the scope of knowledge on genetic disorders in general. Today, the focus is on an area which is very dear to my heart and very passionate about, which is metabolic disorders. So first of all, before we start, just a few housekeeping rules before we get going. So any questions that you may have must be written in the question and answer box, and questions will be answered only during the question and answer panel discussion at the end of the session. The second point is that CME certificates can be downloaded as of tomorrow from the following link, and the link will also be shared in the chat box. We also ask that all of you participate in a short survey and answer the questions at the end of this webinar. So without further ado, let's start with our first esteemed guest speaker, Dr. Fathiya Al-Murshidi. Dr. Fathiya is a senior consultant, clinical and biochemical geneticist at the Genetics and Developmental Medicine Clinic, Sultan Qaboos University in Muscat, Oman, since 2010. She is also the program director for the Medical Genetics Fellowship Program at Sultan Qaboos University Hospital. Her current research interest is in the field of biochemical genetics, disease manifestations, and characterization of new genetic diseases and treatment outcomes. Dr. Al-Murshidi obtained her MD from Sultan Qaboos University in Oman, and this was followed by her residency training in medical genetics at the Hospital for Sick Children, University of Toronto in Canada. And she obtained the fellowship of the Royal College of Physicians of Canada in medical genetics, and she also trained in biochemical genetics at the Hospital for Sick Children. Dr. Fathiya will be giving us an overview of inborn errors of metabolism. Dr. Fathiya, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Amal. I would like to thank the organizers for this kind invitation. And I would like to thank you for this kind introduction. And we are given just 20 minutes, so we are going to start. I had been given indeed a very tough exercise because I was told that I need to explain to you metabolic diseases in 20 minutes. The mission is impossible, but we will try to highlight some general principles. And we'll be happy to receive your questions after this talk. So we'll talk about the definition of inborn errors of metabolism or biochemical genetic disorders, the common disease mechanisms involved, the different clinical presentations, how can you identify patients, the investigations, and the tools we have to confirm the diagnosis, and general management principles at the end. So when we talk about biochemical genetic disorders, we need to define what is metabolism. And metabolism is the set of biochemical reactions involved in the process of breaking down or making various or different molecules in the body. As this beautiful diagram will keep coming into this presentation, basically biochemical processes as we are sitting are involved into obtaining energy from the fuel that we eat, but it is not all about obtaining energy. In the process of obtaining energy, there are numerous pathways that happen, and metabolic intermediates, some of them can be toxic if they exceed their normal limits. But however, these also metabolic pathways will lead for us essential molecules, and these essential molecules can be utilized in making more complex molecules or macromolecules. These macromolecules are going to be broken to us back the elements that we need, the more simple elements or building block that we will be recycling. And I'll be going over and over this principle during this presentation because it's very important. So if we are talking mainly about biochemical reactions, then we have to talk about enzymes, because enzymes are the catalysts of these biochemical reactions. Without enzymes, conversion from a substrate to a product may take forever, and with enzymes it may take a fraction of seconds. So they are beautiful. This is a very beautiful system actually to catalyze biochemical reactions in biological systems. And when we are talking about biological systems and reactions, as I told you, we are talking about conversion of a substance, which is a substrate, into a product. And your substrates could be, as I showed you in that diagram that I like. Remember, I like that diagram. Could be the intermediary metabolism that is involved in generating energy from the fuel in the food, protein, carbohydrates, and fat, but also all biochemical reactions involved in the breaking down of complex molecules or in the synthesis of more complex molecules or important elements in our body from more simple ones. And then, the expected products, there is something. I have a problem here, the mouse is not moving. Okay. So the expected products, depending on your substrates and which biochemical reaction is happening, could be energy substrates like the ATP and ketone bodies, could be less toxic metabolites, starting from more toxic metabolites, or could be, as I said, more simple molecules that are to be utilized for synthesis of small molecules to be excreted or to be recycled, and or to be to make actually more complex structural molecules, like all biosynthesis reactions that happen in our body. And what happens if a person is born without that enzyme? Then this biochemical reaction will be interrupted, and that will result into a disease. And the disease will be linked either to the accumulation of the substrate or deficiency of the product. And then we can imagine then the disease can result from accumulation of the toxic metabolites of intermediary metabolism, what we call as a small molecule intoxication. And when we speak about small molecules, we aren't fan about the molecular weight of that molecule, although this is one of the primary reasons, but we are fan about the intoxication effect of that molecule, because the intoxication effect is going to be rapid and it's going to cross all biological barriers, including the blood-brain barrier, and then a defect in the liver may result into accumulation of substance that is toxic to the brain and can readily reach the brain. So you can have acute systemic manifestations and disorders of intoxicating metabolism. Or this block can result, as I said, in accumulation of complex molecules, and then these complex molecules cannot cross the barriers, they stay where they are, and the damage is going to be local. Or you can have a problem related not to accumulation of the substrate, but lack of the product. And if that product is required to produce energy, then you will have acute or subacute or chronic cellular dysfunction because of energy failure. You may have the result may be, or the disease mechanism may be due to the depletion of important molecules required for various metabolic pathways. If these molecules, by the way, happen to be required for the period of embryogenesis, a person with an inborn errors of metabolism can present with different malformations. And because all enzymes are proteins, are encoded by proteins, so actually the enzymes and the transporters that are required to bring substrates beside the enzymes are proteins that are encoded by genes. So we are talking largely here about single gene disorders. If the gene that is not working happen to be a nuclear gene, then you will have Mendelian inheritance with autosomal recessive, autosomal dominant X-linked, or if it is in the mitochondrial genome, then we will have the non-mitochondrial inheritance, and there is no time to explain these principles here. So just looking at this beautiful diagram again, we can then get the disease mechanisms in inherited metabolic disorders, because if it is about accumulation of toxic metabolites, you will have intoxicating metabolic diseases. If the mechanism can be energy failure, as I say, accumulation of complex molecules, or failure to make or synthesize complex molecules, what we call as biosynthesis defects. And then as we are physicians and healthcare providers, we are thinking about patients and we are thinking about clinical presentations. So you can imagine a patient who was completely fine at birth, and within a very short time, if you can see my arrow, this patient can get very, very sick. If you don't do anything here, this patient may die, but if you do something, you will salvage this patient and he may improve. This patient may improve to reach a completely normal baseline if you really intervened in time, because before irreversible neurological damage happens, or he can have some residual clinical symptoms or damage, most often neurological damage, and then this will be the baseline of the patient. However, remember, these are genetic diseases. The person is born without the enzyme, so throughout their lives, they are at risk of having periods of metabolic decompensations that can result again into accumulation of toxic metabolites, and this person may have irreversible organ damage or death at any of these episodes, and after some of these episodes may have a new baseline. And this is exactly what happens in intoxicating metabolic diseases. In diseases and energy failure, although this is not the rule, but the classic clinical presentation of a completely healthy person, usually a child, at some point with increased energy demand, gets really sick with multiple organ dysfunction, and where he can die or attain irreversible end organ damage. When we are talking about local accumulation of complex molecules, then we are talking about very slowly progressive. There is no acute event here. But this person today is really different from what he was a year ago and a year in the future. And this is really the course in complex metabolic diseases and biosynthesis defects. And many of them, the patients can be born with some malformations or abnormalities, but again, metabolic diseases typically progressive in nature, and the patients get worse with time. So time in every category of metabolic disorders. And when we are talking about disorders, intoxicating metabolic disorders or small molecule intoxicating metabolic disorders, we are talking about of accumulation of toxins proximal before the metabolic block. And the categories that we have are aminoacidopathy, organic acidureas, urea cycle disorders as disorders of protein metabolism. We also have disorders of carbohydrate metabolism like sugar intolerances, and we have the accumulation of methyls and precursors of heme metabolism or heme synthesis pathway. As examples here, I'll talk very briefly about a very common disease, which is or a very famous disease, phenylketonuria. It's an intoxication with an amino acid that results into chronic encephalopathy and progressive loss of cognitive function. It is because of the accumulation of phenylalanine resulting from the absence of phenylalanine hydroxylase or its cofactor. And main clinical phenotype is the intoxication of phenylalanine, although some of the clinical phenotype like the reduced pigmentation and can result from the low tyrosine seen in these patients. So the main phenotype is severe, progressive, irreversible intellectual disability. There is no one point that you can track this patient got sick today or got sick in that specific day. And on top of the fact that these patients typically lighter compared to other members of their family members. In comparison to that, there is another famous aminoacidopathy in Oman in particular. This is the most frequent intoxicating metabolic disease that we have. We have over 50 patients with maple syrup urine disease. And what happens in maple syrup urine disease, babies are born without a branch chain keto acid dehydrogenase, and that will result into accumulation in the branch chain amino acids, which are leucine, isoleucine, and valine, and their branch chain keto acid equivalents, and that is very toxic to the brain, result into a really progressive encephalopathy, acute encephalopathy that can result in death or irreversible neurological damage if the intervention happens late. And this is just to show you one of the stages of the progressive encephalopathy when the babies really have poor cry. And you can see here a hallmark of the movement this baby has. This baby is a 1 week old. And look at the pedaling movements, the cyclic movements of the upper limbs and lower limbs, which is characteristic of the acute encephalopathy of MSUD. Again, accumulation of toxic metabolites. As an example, what we see from the accumulation of galactose 1-phosphate in galactosemia, where the galactose and lactose cannot be metabolized because these patients are born with absent galactose 1-phosphate uridyl transferase enzyme, and accumulation of galactose 1-phosphate results into what we know about the classical presentation of galactosemia with hypoglycemia, jaundice, liver failure, cataract, increased risk of gram-negative sepsis. If you save these babies and treat them in the neonatal or early infantile period, these babies will still have increased risk of long-term complications like learning disability, mild intellectual disability, premature ovarian failure in the females, and osteopenia and osteoporosis. When we talk about energy failure, and I have no time, and so we are talking about acute or chronic cellular dysfunction because lack of energy, production or utilization, and or there is inability. So this is either because the energy producing machine, the mitochondria, is not able to work, or because there is no enough fuel supply. Then that happens in disorders where you cannot supply enough glucose, like disorders of gluconeogenesis or glycogen storage diseases or fatty acid oxidation disorders. Examples of mitochondrial disorders, we have more than 1,500 mitochondrial disorders at the time being. Examples of categories are congenital lactic acidosis, mitochondrial DNA depletion syndrome, and the famous respiratory chain disorders. Other organelles where the defects in biochemical processes in them can produce diseases, including lysosomes, peroxisomes, and biosynthesis defects. Remember that when we make very important molecules from precursor molecules like cholesterol biosynthesis defects and congenital disorders of glycosylation. And I'll skip fast. This is an example of lysosomal storage disease, which is mucopolysaccharidosis. Depending on the mucopolysaccharide, this is a complex molecule disorder. Depending on the distribution of the accumulation of the complex molecule, you can get somewhat distinctive phenotypes of even mucopolysaccharidosis. Peroxisomal dysfunction is very dangerous because peroxisomes are very essential organs, and the famous disease, Zellweger syndrome, results when peroxisomes are absent, and that leads to progressive loss of cellular dysfunction of vital organs and early death, and the characteristic features we know. So the clinical presentation can be at any age, can be at any organ system. Typically, we see more presentation in the neonatal and infancy and childhood periods where the effect of single gene dysfunction is more seen, but the patient can present to you with acute encephalopathy, epileptic encephalopathy, any new neurological dysfunction. You need to think about a metabolic disease, if you have abnormalities in the liver, spleen, if the patient is presenting with hepatosplenomegaly or hepatocellular dysfunction or conjugated hyperbiliary. Gastrointestinal presentation can be the presentation actually of metabolic disease with cyclic vomiting or pancreatitis. The heart can be involved and can be the first organ to manifest. The kidney can have very variable presentation in different in different biochemical disorders, and the eye is the key for many metabolic diseases as well. as well as the skeletal system. Not only that, patient can present with sudden death, can present with dysmorphic features, can present with hair and skin changes, hydrops fetalis, or bone marrow suppression. So clinical presentation is really huge because biochemical reactions are just involved in the synthesis of every kind of molecule or a breakdown of every kind of molecule in our body. There are some characteristic features or even smells we find on clinical examination that can be a clue for certain diagnosis. There are characteristic eye changes, the corneal clouding you see in mucopolysaccharidosis, the famous cherry red spot that you see in some lysosomal storage diseases, the external ophthalmoplegia you see in mitochondrial diseases, and the cataract. The hair and skin changes can be clue for some diseases as well. And the skeletal changes can be clue for a number of diseases. The most obvious example is the cystosis multiplex and mucopolysaccharidosis. When we talk about investigations, it's based on our understanding of the pathophysiology of these diseases. There is an absent enzyme that was coded by the DNA, and there is an messenger RNA in the middle. And if that enzyme is not working, there will be accumulation of metabolites. So investigations are based on actually profiling these accumulated metabolites or actually doing an enzyme assay. And last but not least, what actually changed the equation completely in the past decade is the progress in genetic and the ability to for genetic analysis, where we can diagnose many of these disorders now molecularly, and we are depending less and less on tissue diagnosis or enzyme assays. So targeted mutation analysis, gene sequencing, multi-gene panels, or genomic profiling with the whole exome sequencing or whole genome sequencing are essential part in the investigation of these patients. The metabolic changes can be seen in the blood, in the urine, in the CSF, or actually in the tissues. These biochemical changes can be actually secondary to the tissue damage or infiltration, that like the elevated CK, or can be just seen and profiled of what we know about what is proximal to the block and what is distal to the block. And these are just examples of metabolites that we see, but not limited to this very small list. Or we can measure the enzyme activity. We can see the changes in the tissues for complex diseases. And these are the vacuolated lymphocytes, the Gaucher cells, the ragged red muscle fibers, and this is the glycogen stored in the liver and glycogen storage diseases. When we talk about management, there are certain principles in management, and again, management, similar to investigation, is based on our understanding of disease mechanisms. So we can, because there is accumulation of the substrate, we can remove the excess substrate either by dialysis or by medications, or else we can reduce the intake of that substrate. We can supplement the patient with a cofactor to the enzyme so we can further enhance the enzyme activity, or we can actually replace the missing enzyme by enzyme replacing therapy, or by gene therapy, or by transplant, or we can replace the deficient products as well. And this is just example about the dietary management that is still widely used in intoxicating metabolic diseases, cofactor supplementation. I want to stop at this one slide of enzyme replacement therapy because it became the standard of care for a number of lysosomal storage diseases, included Pompe disease, Gaucher disease, some MPSs, and Fabry. I want you to know that enzyme replacement therapy is not cure, but we use it because it can greatly modify or attenuate the phenotype of the patient and improve the quality of life. But the price is very high, not just the price of the medication, but the price the patient pays, because these are regular lifelong infusions. There is hypersensitivity reaction that may actually lead to the formation of a neutralizing antibodies. So again, this is a repeat with some examples. If we have a disease that is resulting from accumulation of the product, one mechanism that we target, that we go to the enzyme before to that step, and we inhibit that enzyme, and we call that substrate reduction therapy. And we see this in real life. Now we have Serdilga, which is the eliglostat that is utilized in Gaucher patients, We can replace or improve the function of the gene through gene therapy, enzyme replacement therapy, chaperones, which are stabilizers for the protein or for the malfunctioning or misfolded enzyme. And again, in real life, we have it in Fabry disease, the migalastat that is used in Fabry disease, or we can do organ transplant. So these fancy treatment modalities are present, but I want you to know one thing, that supportive care, despite the absence or the availability of a curative treatment, is by far the most important and feasible aspect of patient management. And because it is very important, you need really to educate yourself about what do you need to support this patient. So you need to do good surveillance of the functions of the organ systems expected to be affected by the disease, including everything related specifically to this disease. You need to do assessment and support the mobility and nutrition, treat seizures, treat psychiatric disturbances, and changing the lifestyle, because if the patient is at risk of atlantoaxial subluxation or he has a huge spleen, you prevent contact sports, for example. And because they are very important, we have actually guidelines that are made by experts in the field for some of these diseases. Remember, these are all progressive diseases, so your supportive care is actually a dynamic process, and the change of care requirements is needed as the disease progresses. You need also to know what is the time to stop, how to alleviate all the discomfort around the end stages of the disease of the patient. So this is my last slide. I'm sorry to take more than my time, but we are talking about a hugely clinically heterogeneous group of mainly serious and life-threatening diseases. All are progressive, majority are life-threatening, and there is a treatment in some cases. How to know the patient? Pay attention to the phenotype or clinical presentation of the patient. Look at organ dysfunction. It can present acutely or subacutely or chronic organ dysfunction. In some patients, you can see suggestive biochemical changes, elevated ammonia, metabolic acidosis, elevated lactate, and so on. Diseases with a worsening or increasing severity of the time, you need to think about metabolic diseases, a plateau or regression of development, or multiple organ system involvement. Making a diagnosis is very important, because you cannot go for targeted treatment modalities if you don't have a diagnosis. But even if you don't have a diagnosis, if you don't have a treatment, you need diagnosis, because you need to provide the appropriate supportive care, and you need to provide genetic counseling, which is essential to support these families and for the prevention of further recurrence of these diseases. I'm done. Thank you very much, and we'll be ready at the end of the 2 sessions to take your questions. Thank you.
Thank you very much, Dr. Fathia, for your excellent presentation. I think you did a great job. Summarizing inborn errors of metabolism in 30 minutes is not an easy task. And I think you did great. You made it really clear, and you gave a simplified overview of metabolic disorders. So as mentioned, the question and answer sessions will be at the end of the presentation after the second talk. So allow me now to introduce our next esteemed speaker, Dr. David Casper. Dr. Casper graduated from the Vienna University of Technology and holds doctorates both in technical science and medical science. He became an associate professor within 6 years and heading the lab at the Department of Pediatrics and Adolescent Medicine in the Medical University of Vienna, the Austrian Newborn Screening Program, and the Lab for Inherited Metabolic Diseases. Dr. David is very active in developing different methodologies to expand the screening panels for disorders such as lysosomal storage diseases. His career-long biochemical research focus has been on different topics, and his specific focus today will be on the development and evaluation of novel lab assays to improve and accelerate diagnostics in children. So his topic today will be focused on newborn screening for metachromatic leukodystrophy. The floor is yours, Dr. David.
Hello, everyone. Thank you very much for this kind invitation, and thanks to the organizer for having me today. So I would like to talk a bit more specific on rare disease screening and diagnostics on the example of metachromatic leukodystrophy. As we heard from our previous speaker, she really well summarized, Dr. Al-Moshedi, the complexity and the wide range of metabolic diseases. And in most inherited metabolic disorders, a single enzyme is either not produced by the body, as we have heard, due to a mutation, or it is not produced in a form that does not work properly. So depending on that enzyme's job, its absence means toxic chemicals may build up or an essential product may not be produced. And I would like to show you today a bit more practical approach for you as a physician in your daily life, identifying and then subsequently treating patients with rare diseases. And metachromatic leukodystrophy is a devastating disease, and I would like to show you today on a role model how to identify these patients, maybe also at newborn stage, but also with elderly, and what kind of laboratory diagnostics procedures are now available to identify these patients at risk. Before I will start, I would like to show you just briefly what we do at ArchiMedLife, which is a medical laboratory that has served more than 25,000 physicians from more than 80 countries worldwide. And why is this so of importance? Because rare diseases are so rare, and some of these diseases are maybe with an incidence of 1 to 100 or maybe 1 to 500,000. So we have to gain knowledge together with physicians from all over the world to better characterize, to better identify, and also to better understand these kind of metabolic diseases. And there are hundreds of different metabolic diseases that we have to have in our mind when we see patients, when we start diagnostics and diagnosis. So we have to have a full laboratory service from clinical mass spectrometry to next generation sequencing that we need to identify our patients at risk. And here is just briefly our medical laboratory located in Vienna. And please visit us also at archimedlife.com to see what kind of diagnostic services we offer. And we are one of 90 sites of the MEDIS network. And we also have a MedLab in the healthcare city in Dubai. And it's a company and network of more than 4,000 employees and 400 physicians and scientists in our group. What is also of utmost of importance is that we share our knowledge. So we and many physicians are sharing their knowledge by international peer-reviewed publications and by oral presentations worldwide. So also all our knowledge that we gain at ArchiMedLife, working together with thousands of physicians, identifying hundreds or thousands of patients per year, we all disseminate this information to raise disease awareness, to educate, and we are also active member in several international advisory reports where we discuss novel biomarker and diagnostics. And as I mentioned in the beginning, today I want to speak about this devastating disease, metachromatic leukodystrophy. And it is a rare, fatal autosomal recessive genetic disorder. And it is rare, and we don't know how many kids are really suffering from this kind of disease. Maybe it's 40,000 or an incidence of 160,000. We do not know yet, because many of these babies die in the first months of life. But what we know is that metachromatic leukodystrophy, or MLD, is caused by an insufficient activity of the enzyme aryl sulfatase A. And this accumulation of toxic sulfites leads to this progressive demyelination and neurodegeneration. And whenever these children are becoming suspicious, clinically suspicious, it is may also too late for treatment. But nonetheless, there's 3 variants of MLD. There's the late infantile MLD, the juvenile MLD, and even an adult MLD. But nonetheless, all these types or onset of MLDs share the same underlying pathophysiology, and they are progressive, and they are ultimately affecting both the intellectual and the motor functions. And with many of the metabolic diseases that we know so far, an early diagnosis is of utmost of importance. But unfortunately for MLD diagnosis, this is often delayed or is often missed. So we need better diagnostics. And I would like to show you from a practical approach in rare metabolic diseases, how you can have access to such diagnostics programs where you can identify these kind of patients that are at risk. So I also would like to introduce to you in the Middle East programs that are organized by GenPharm and supported by Orchard Therapeutics, where we have a new diagnostic program where we can do a new biomarker test that is including the sulfatides from dried blood spots. Unfortunately, as I show here in these pictures, is that we have these kind of dried blood spot sampling where you put from a heel prick a few drops of blood to this filter paper card, or you use these filter paper cards also from finger pricks. So it means we only need a few drops of blood and we can identify dozens or even hundreds of different metabolic diseases. We can perform enzymatic testing, biomarker testing, or we can also run large gene panels using next generation sequencing. And with the ability of these kind of diagnostic tools that we have available for physicians for their daily clinical life, we can offer these kind of programs to you. And this is what I would like to show you for metachromatic leukodystrophy today, that there is a novel biomarker test identifying a sulfatide profile from these kind of dried blood spots. And only with these few dried blood spots that we need for our diagnostic service, we can identify potential patients that are at risk of metachromatic leukodystrophy. And furthermore, what is also of utmost of importance for you as a physician is that you have a panel diagnostic, a differential diagnostics available. So we will start a program in your region where we will do the sulfatide screening that we use for the MLD. But moreover, it is also possible from these dried blood spot cards that we also measure galactosylceramidase for morbus Gravi disease, hexaminidase for Tay-Sachs and Sandhoff, and we can even measure enzymes for CLN1 and CLN2, where we do additionally this kind of testing. And this is all available just using dried blood spots, a few drops of blood. And this is what I would like to show you today, what kind of diagnostics or biomarker testing or even newborn screening is available to identify these kind of patients suffering from metachromatic leukodystrophy. So when you're interested in joining such international efforts to identify these kind of patients, we would be happy if you would register at our web portal for physicians at webportal.archimedlife.com, where you can easily order this kind of diagnostic service and sampling kits, and where you also have your results, your medical reports available 24/7, and you get full online support and newsletters. And what you need to identify any of these rare metabolic disorders is just a dried blood spot sampling kit. So you just need a dried blood spot card, a filter paper card that you may already use in your daily routine life for newborn screening or also for testing children for any other genetic diseases. So you need this filter paper card, you need an informed consent form, and then you collect the sample and return it and this is very easy, a very handy tool to identify patients at risk. And what we have launched is for Metachromatic Glucodystrophy, this kind of diagnostic service where you can use the dry blood spot cards for panel diagnostic and or the sulfatide screening, and it's very easy, you will see when you enter this web portal. So why do we do this? Metachromatic Glucodystrophy is a devastating disease, and there was no treatment available. But this has changed significantly, and this is what I would like to show you, how a new therapy can trigger also diagnostic support and disease awareness. And in Germany, we have started a prospective newborn screening study. Why newborn screening is so important is very easy, because we do a prospective screening for sulfatides, for this toxic accumulation in blood that we can also already detect a few days after birth. So newborn screening is a widely used tool, as we have heard from Dr. Al-Moshedi in the previous talk before, where you can test, for example, for phenylketonuria, for maple syrup disease. So you have already in a lot of countries these tools available, where you collect a few drops of blood after birth and then test for various diseases. So what we have started in Germany in the collaboration with the Hanover Screening Laboratory is the implementation of a sulfatide screening test for MLD into the current newborn screening program. And we got the approval of the ethics committee in summer, and we started now in autumn 2021, including approximately 50,000, 55,000 newborns per year. This is the number that we anticipated. And what we will do in this kind of additional testing is that we do the sulfatide testing, including genetic confirmatory testing. And why is this so important that we are searching for this kind of metabolic disease? Because we have established in Germany a treatment center in Tübingen, and they are offering the first time a gene therapy. So what makes it really unique here is that we have the chance not only to identify the patients at risk and provide family counseling and symptomatic therapy, we have now the possibility with the first available therapy that functional copies of the ARSA gene are inserted into the genome of the hematopoietic stem cells using a self-inactivating virus, a vector that is inserting this gene, so that these genetically modified cells can be infused back and the patient can start producing the enzyme. So this is a completely new approach of gene therapy that gives us much hope that these kinds of diseases can be treated or even cured in the next years. So what we have to do, and that's the reason why newborn screening is such a vital tool and so important, is that with newborn screening we can have a prospective screening of some maybe or asymptomatic patients. So with our prospective screening, we can identify potential babies that are at risk for MLD and bring them to a treatment process. And to enable this, we have modified and adapted a method that was developed by Professor Gelb at the University of Washington in Seattle. And what we have developed is a mass spectrometry assay where we can do the sulfatide screening from the residual sample from newborn screening, where we quantify several sulfatides. We only need 2 minutes per sample, which allows us in a high volume measurement, in a high volume setting like newborn screening, to analyze hundreds or even 1,000 samples per day with mass spectrometry. And we have developed and validated a new method that was also fully accredited and approved by the Austrian government. So what we have done so far is that we have established this kind of sulfatide screening assay in our lab that allows us to screen hundreds of thousands of babies per week. And I would like to show you the first results from our pilot study that we also performed together with Hamburg University. So we screened hundreds and thousands of samples for the sulfatide profile. And what we had is we had positive samples from MLT patients, and we could identify these kind of patients using our sulfatide profile test assay. So we randomly put these kind of positive samples into the thousands of newborn screening samples that we had, and we could clearly identify these are the patients where you see this in green. And we could identify newborn, but we also could identify infants or elderly children suffering from MLD. So we have a screening test available that we now test prospectively in Hanover for the next month and years, and also maybe in other countries, in other screening centers, because we would like to gain knowledge how we can implement such a sulfatide screening assay in the daily routine newborn screening laboratory to identify babies at risk. And on the other hand, we have the diagnostic test, as I showed you before, where we have with a panel diagnostic approach the possibility to measure different enzymes, including the sulfatides, from a few drops of blood. So we have the ability now that we have novel diagnostic methods available that we can identify these kinds of patients. And I would like in my acknowledgement to thank the screening laboratory in Hanover and in Hamburg, but also Orchard for the great support and the start of the first newborn screening program and diagnostic service, as well as for Enzyme for organization, and all our team members that are working hard to get this kind of diagnostic test for you available. Thank you very much.
Thank you very much, Dr. Casper. This was a wonderful talk, highlighting the importance of newborn screening and the power it gives us in terms of early diagnosis and the wonderful therapies that are emerging in the recent years. So we've reached the question and answer session. Thank you all for staying with us. Allow me again to thank Dr. Fathiya Al-Murshidi and Dr. Casper. So we'll move now to the question and answer session. So the first question, I think this probably Dr. Fathiya, can you address this question? So what is the best testing option in terms of metabolic disorder diagnosis? Is it based on phenotypic or genotypic methods?
Okay. Can you hear me? Yes. So I don't think we can give away with understanding the phenotype if we are healthcare providers for many, many reasons. Even if you genome every baby at birth and you know every genetic defect in him, remember we are at the end treating patients. So even an approach, even an understanding, so to understand what does this disease is doing for the patients, with what organ systems are involved, I mean, what is the progress? So I think I'm a person who is really going with, we can use the genotype to understand the phenotype. Our main aim is to understand what's wrong with our patient and help that patient. And I don't think any instrument can tell you that. So you need to understand your patient differently. And depending, actually, even the approach for test is completely dependent on understanding the phenotype, and giving meaning to genetic results is also dependent on the phenotype of the patients, because genetic results without understanding the phenotype are meaningless. Because if you have a gene defect, which is for which the gene is unexpressed in an organ that is not really affected in your patient, and your patient has a different problem, then probably even if that leads to loss of function, that's not the problem of your patients. So yes, genetic diagnosis is very important, is essential, but it's a tool to understand and help the patient with a certain phenotype.
Perfect. I would agree with your points. I mean, the phenotype is very important and essential, and it guides how you approach your patient in terms of testing. So this is also another question directed to you, Dr. Fathiya. So what are the common disorders seen in Oman? Can you share your experience?
Okay. We see really a very big spread of multiple disorders. Some of them are more common, and we see a lot of ultra-rare disorders, and there are significant bunch of disorders where the first disease description came from Oman, and this is coming from the fact that we are endogamic population, and there are there are multiple genetic isolates and consanguineous marriage like all other neighborhood countries. And intoxicating diseases, as I told you, the most frequent disease is maple syrup urine disease. Surprisingly, we have very, very few phenylketonuria, and I think this is because we don't have a newborn screening for phenylketonuria in Oman. I'm sure we have many more than what we have now. We have a large number of organic acidemias, mainly isovaleric acidemia, but also propionic acidemia, methylmalonic acidemia. We have all sorts of fatty acid oxidation disorders. We have a large number of patients with carbonic anhydrase 5A deficiency. I think we have a large group of patients, more than the number that is described in literature so far. If I'm not mistaken, we would have 15 patients. Mucopolysaccharidosis are also common, and we have LSDs, lysosomal storage disease in general. We have, I think, pretty between our hospital and our other reference center in Oman, the Royal Hospital, we have really large number, like we have hundreds of patients for a small population of less than 5 million. And also mitochondrial disorders of different sorts, mainly nuclear early onset mitochondrial disorders.
Okay. So it seems like you are very busy, given all of these disorders that are very common in Oman. There's also another question to follow up on your comment regarding newborn screening in Oman. So does newborn screening exist, and what are the conditions that you screen for in Oman?
Okay. So Oman is screening for congenital hypothyroidism and is screening for congenital hearing loss. It was very early to start screening for congenital hearing loss. Actually, it was surprisingly early for a country that doesn't have expanded newborn screening for metabolic disease and up to date. But we are actively working on it, and we are hoping that it will see light sometime soon, inshallah.
Inshallah.
But currently only congenital hypothyroidism and congenital hearing loss.
Okay, so I'm sure you see many of these acute intoxication disorders given the absence of newborn screening, and your task is much more difficult than any other physician working in a country like Oman. So we'll move on to the next question. What's the best time to test a child for a metabolic disorder screening, especially considering the option of next generation sequencing option? So if I can understand the question correctly, what is the best time to do the screening for any metabolic disorder, and complementing the biochemical with genetic, is that an option?
And it's for me as well. Okay, so when we talk about, it depends on what are we looking for. Again, if we are looking for, it depends on the age of onset and then how acute are the manifestations of the disease. If we are talking about intoxicating metabolic diseases, then we would like to have the result before the first week of life, ideally by between day 5 to day 7 of life. If we have, there will be disorders that present before that and cannot be catched by newborn screening. Again, if we are, there are some disorders that are less acute, but again, we have to diagnose them and treat them in the neonatal period as well. And for later onset lysosomal storage diseases, I really don't know because I haven't been involved in such discussions in the past.
Thank you. Dr. Casper, do you have any comments regarding this question?
I think it was already answered very well for Dr. Fatia. The only thing I would like to add is that next generation sequencing, or let's say analyzing thousands of genes immediately at birth, does not really make that much sense because it's very difficult to interpret and will cause a lot of anxiety also of the parents at that stage. So what I more emphasize is to do a great newborn screening panel, maybe for some amino acidopathías, organic acidureas, fatty acid oxidation disorders, as outlined already today. And then if the baby is of clinical suspicion for any metabolic diseases, or when we have in the family a history that the one or the other parent, nephew, whoever was sick, that we also screen for additionally diseases. And then we have, not for all of these 1,300 metabolic diseases or much more, we have a treatment available, but we have at least for some of these. And for example, for Metachromatic Glucodystrophy, we have these future treatments on the horizon. So it is really, so we have the possibility of gene therapy, or maybe also for other diseases soon. So we should test for much more diseases immediately after birth, like in newborn screening. So for more lysosomal storage disorders, for example, for other leukodystrophies, or even XALD or other diseases, So I think we should expand the newborn screening maybe to 40, 50, 60 diseases, That would be the best, And then when we have clinically suspicious babies, then also may use other biochemical testing or next generation sequencing with different panels for muscle, neurodegeneration, and so on and so forth. But starting with newborn screening is great, but there's a lot of work to do in the next years, also with respect to the novel treatments that are coming up, that we implement more and more diseases in newborn screening programs.
Correct. I totally agree with you. There's also a question regarding the status of gene therapy for inborn errors of metabolism. What's the present status and the future? I think I will leave this question open. Whoever would like to take this task of answering the question. Dr. Fatia?
Okay. We just heard Dr. Casper talking about the treatment coming for metachromatic leukodystrophy, and that is a very good example of gene therapy application. I think from my understanding up to date, this is the only inborn error of metabolism by definition that we have a real, we have reached this stage of gene therapy. There are gene therapy is available as and is existing actually now. It was a dream a few decades ago, and there were periods where people gave up on it as well because of the many obstacles that happen. But we have it in reality for spinal muscular atrophy now. There is gene therapy for hemophilia. There are more and more diseases under clinical trials for gene therapy. I don't know all of them, to tell you the truth, but I know that the success of these first trials, our success with MLD, with SMA, with hemophilia will definitely lead to expansion and acceleration of gene therapy in the future. But in real life, it is very limited now to very few diseases, as far as I know. Dr. Casper?
No, totally.
Can you add to this, please?
I'm sorry?
Do you have anything else in mind to add to this? Because
No,
I'm not aware about all clinical trials in gene therapy.
No, we have a great future. I think there's so many gene therapies at the moment in clinical trials under investigation. So, for example, not only for Metachromatic Glucodystrophy, which is already approved by EMA, in European Union, but also for others, like CLN, is coming, gene therapies. There are many more gene therapies coming for monogenetic metabolic disorders. So I think we have a bright future. So in the next 5-10 years, I think a lot of these kind of gene therapies with new approaches will come to the market and will be available. So that's the reason why we also have to build up these prospective screening programs to identify these kind of patients early after birth, that we also have the chance of a treatment at the very early stage of life available to have the best clinical outcome, because these are all, as you mentioned, progressive diseases, and they are causing all damage that are irreversible. So we have to identify and treat the baby as soon as possible after birth. And gene therapy, we really have the gene therapies are on the horizon, and there are several trials for many diseases. So I think the next 5 to 10 years will be really, really exciting to see what kind of therapies will come to the market, what is the clinical outcome of these gene therapies. Can diseases be cured? As we see in severe combined immunodeficiency. So we have a chance, to cure also diseases, when we at the early stage with stem cell transplantation and so on and so forth. I think medicine will make great progress in the next decade on this topic.
Perfect. I think I would agree with you. We're living in a very exciting era, and I think the future is very bright, and hopefully more gene therapies will be available for more and more diseases in the coming years. Okay, so the next question, how can you distinguish between a single gene disorder and a multi-gene or complex disorder in a single patient?
That's a very complex question.
I agree with you.
It's not so easy to answer. So in principle, if the baby or the child is already clinically suspicious, you maybe group, let's say, the symptoms or the clinical symptoms, and say, okay, if you use some gene as a genetic testing, you may go, for example, for muscular diseases, you go into a gene panel for muscular diseases or in neurological diseases, and then you might find the cause of the disease. But it's not so easy, say, to start with a single gene or a multiple gene examination. So in principle, if the baby or if the child is you have to go to a clinician who has knowledge about the disease and who's an expert, and you have to categorize the disease. And then you also have to start searching for the appropriate laboratory diagnostic, radiology, or the others, that you finally receive a diagnosis. And then there's maybe a single gene or a multiple gene involvement, but this is a complex process that you have to do with your clinical experts, with your laboratory, and so on and so forth.
Thank you, Dr. Casper, for taking on the mission of answering this difficult question. We'll move on to the next question. So I'll read the question. I'm not sure that I understood, but maybe our speakers can comment on this. So can we imagine any therapeutic manipulation of alternative pathways which can be activated in inborn areas of metabolism and lead to complications? So I'm not sure I understood the question, if any of you want to comment.
I think I know what they, maybe I know what they mean.
Okay.
And I think here they are asking about if our interventions themselves can cause problems for the patient. Is that the question?
I think that's what I understood as well.
And so, definitely any intervention, any medical intervention has its cost, right? So if we talk about approaches like reduction of the substrate. And if we take an example, dietary treatment for patients with intoxicating metabolic diseases, then we know that dietary restriction can result in multiple health problems that, depending on the dietary restriction we are placing in our patient, we are careful of monitoring the expected complications that can happen because of this dietary regimen or the dietary treatment. For example, we know what are the risks of low protein diet. We monitor that based on clinical assessment of the patient, based on laboratory investigations, and we correct on time and so on. But yes, we need to know that every manipulation of a biochemical pathway will result into expected changes, other unwanted changes because of this manipulation. And these aren't cures. The exciting thing about gene therapy that it will be the cure and it will just correct the gene. But I think as exciting as the era we are living with the new developing treatment, we are still blinded to the future. So we are still, it's too early to say what is going to come throughout the years in patients who receive gene therapy. It's too soon to comment. And Dr. Casper, I don't know if you have, if you want to add anything here.
Not here, thank you very much.
Okay, so the next question, what are the clinical indications or diseases for which we should go for transcriptome analysis?
Okay. Anna?
Yeah.
Okay. So what is transcriptome? Do you understand what's a transcriptome? What's a transcript of the gene is the RNA produced, transcribed from that gene, right? And the RNA is your tool that will be translated to produce your protein. And this means that we usually, at the present time, we usually present with DNA analysis. Sometimes when we do DNA analysis, we come to ambiguities. And in these ambiguities, looking at the RNA produced from this DNA can help us. This happens if we have, for example, changes in the DNA in areas that are very difficult to know, but we know that they will affect primarily the RNA produced. If we have changes in the promoter region, and if we have changes in a splice site where we expect that we will not see the RNA actually. So that this will help us to decide if the change in the DNA that we saw is disease causing or not disease causing. So for me at the present time, this is the primary function where I use transcripts of the gene. However, also people argue that combining genomic sequencing with a transcriptome, like if you do whole genome sequencing and transcriptome at the same time, you will be better able to make meaningful information of genetic variants that you face at the time of analysis. I think I didn't try that myself. I don't know about you, Dr. Aman or Dr. Casper, but I think at the moment, at the present time, this is a more expensive approach. It may be feasible with time. It may be more valuable with time, but now this is the main indication where we do transcriptome analysis or transcript analysis for a single gene.
Mm-hmm. I totally agree with you.
Is clear? Is the answer clear?
Yes, I think it's clear, and I agree with you. We usually reserve the transcriptome analysis in cases where we either do not find an answer with the traditional genetic testing, or we kind of cannot find any abnormality, and we reserve it for a research basis, actually. Okay. So I think most of the questions were answered. If anyone has any further questions, please submit it to the question and answer box. Okay, so here's one question. Is there any enzyme supplement approach for enzyme defect treatment? So I think we mentioned, maybe Dr. Fathiya, if you can.
Yeah, we spoke about enzyme replacement therapy. And at the present times, all enzymes except one are actually intravenous infusions. And so the patient will have to come for intravenous infusion. I don't know what do you mean by supplement. Do you mean cofactor? If that is meant enzyme supplement, if you mean by a cofactor for enzyme supplement, then yes, we use cofactor treatment and multiple examples of biochemical defects, but enzyme supplement means enzyme replacement therapy at the time being.
Perfect.
I don't think I made it clear enough. I don't know, Dr. Amel or Dr. Casper, if you want to clarify it.
No, I think that's clear. Yeah.
So we have another question. Is enzyme therapy useful for CFTR therapy, meaning cystic fibrosis?
The new modalities of treatment. Now, I'm not an expert in cystic fibrosis treatment. Dr. Casper, please take over if you have more experience with that, but it is not an enzyme replacement therapy. This is a protein. This is a transmembrane protein. And then the modalities, the new modalities of treatment, depending on the mutation, actually. And I'm not sure if there are oligonucleotide sequence. I'm not updated about the variant medications we have because we have more than one in cystic fibrosis. But what I know that they are dependent on the mutation mechanism. I don't know if you know more about that, Dr. Casper or Dr. Amel. But these not enzymes because CFTR is not an enzyme.
No, there is only a therapy available for 1 or 2% of the patients that having a certain mutation, with exon skipping. But for most of the other patients presenting with symptoms, you only have a symptomatic therapy. There's more coming on cystic fibrosis, but it's a very large gene, and I think around 800 malign mutations have been described. But there's no one single gene therapy that's covering all mutations available now. Most of the cystic fibrosis patients are treated symptomatically. Yeah.
Yes, I agree. Great. So thank you all for staying with us. And I would like just to give you a few comments before we end. Okay. So we need your feedback. Please fill in the short survey. CME certificates can be downloaded as of tomorrow from the following link. And our next event is the 9th Pan-Arab Human Genetics Conference. This is a very exciting meeting where the geneticists from the Arab world come together and we share knowledge, and there's lots of exciting workshops. It's taking place from the 8th to the 9th of December. So I invite all of you to attend the meeting. I would like to end by thanking our speakers, Dr. Fathiya Al-Murshidi and Dr. David Casper. It was a wonderful webinar. Thank you for your contribution, your knowledge that you shared, and the wonderful interactions. And I hope to see you in the future, face-to-face, hopefully. So we'll give the participants a few minutes to fill in the poll and give us their surveys. You have any other final comments, Dr. Casper or Dr. Fathiya?
No, indeed. Thank you very much.
Thank you very much for having us here today. It was a pleasure, and we're much looking forward. If there are any more questions or information needed, you're very welcome to contact us.
Thank you very much. Thank you. Thank you. Have a nice evening, everyone. Thank you.
Thank you.
مع السلامة. Thank you very much.
Bye. Have a good evening. Bye.